Welcome everybody to the Prenuvo webinar covering respiratory diseases, lung cancer, and whole body MRI. So just to get it started, Dr. Vikash Modi is Director of Preventive Medicine, Dr. Abraham Salinas, a radiologist, and myself, I look after our physician relations. Who we are, Prenuvo, we are a dedicated whole body MRI screening service. We operate 12 clinics across the country. Think we should actually update this number. We just opened 2 new clinics this week, one in Minneapolis and one in upstate New York in Buffalo. We are opening more on a regular basis. We have probably another 3 or 4 that are going to come in the back half of this year. We're constantly expanding and looking at international expansion next year. Our focus is patient-centered radiology. We focus on routine longitudinal whole body MRI screening for a proactive approach to healthcare. And this is looking at anything from the top of your head down to your ankles and identifying spots that we can either help improve, reverse conditions, or identify things that need to be addressed. Our expertise, we've got 15 years of doing whole body MRIs. We have been playing an integral role in the advancement of MRI applications for whole body screening, clinical translations of techniques. We've been working with writing white papers and doing research projects in order to really advance and progress the world of whole body MRIs. And it's a big part of the reason that we do what we're doing today. A lot of people look at it and think that it's a new technology or that it's a new approach, and it's not. We've been doing this for quite some time now. And we're constantly evolving and improving our feedback from both patients and physicians and providers that we work with. We work with both. We process feedback. We have a really solid closed loop process in which we work with both patients and medical practitioners in order to take their feedback and ideas and approaches and integrate it into what we're doing in order to keep pushing it forward and advancing our technology and the industry as a whole. One thing that I will say just quickly about us is that we take a very different approach to imaging facilities. This picture here is actually one of our facilities. This isn't made up. Our approach is very warm and friendly. We're very much med spa, so to speak. We want people to be comfortable. We want them to feel welcome and safe. We want them to reduce the level of anxiety that people feel when they come into an imaging facility. It is, statistics show that people frequently come in with a high level of anxiety. They're coming in to be tested for or checked for something. And so we want to try to reduce that as much as we can. So we have warm, welcoming environments. We have a consistent look and feel across all of our clinics throughout the United States and Canada. And so when you enter, you're welcomed by our staff. They're warm, they're friendly. We've got couches and big comfy chairs. We've got water. We've got all the things that you need to make you feel comfortable. Our MRI machines they're wide bore, open-ended, memory foam pads on the table. The entire scan from the top of your head to your ankles takes less than 60 minutes. And throughout that process, you get to watch Netflix or listen to Spotify or whatever relaxation music you want. I have to be honest, it doesn't totally eliminate the sounds from the MRI machine. As anybody who's ever been in one knows, they're loud. However, it does a great job of distracting you and making you feel a lot more comfortable while you're having it done. That's our facilities. We really focus on the safety or the comfort of our patients. We want people to feel comfortable and have a reduction in that anxiety that they feel when they're coming in. At this point in time, I'm going to turn it over to Dr. Vikash Modi, who will walk us through this, and then Dr. Abraham Salinas, who will cover off some case studies. So over to you, Dr. Modi.
Thank you very much, York. Welcome again to everybody who's able to attend today and who's able to watch asynchronously on our recording. We are here to discuss respiratory disease and lung cancer screening. You'll notice a theme with these webinars that we're starting to do monthly, that it is currently National Lung Month in August, and August the 1st was World Lung Cancer Day. And we'll see sort of health observances matching with these presentations to really continue to bring awareness to each of the health conditions that we at Prenuvo and then medically as a community believe that we can improve the screening and detection of disease with. We hope that you'll contribute to these webinars with questions and giving us insights back because we can always improve the processes. So the fundamental problem I'm going to present today is that our current, again, medical recommendations for lung disease screening and lung cancer screening are sort of limited in today's present healthcare environment. We are going to take the look of lung cancer, for instance, which is the second most common cancer in both men and women in the United States, not counting skin. In men, prostate cancer is more common, while breast is more common in women. Those individually have 70 and 80% screening rates, while lung cancer falls to a paltry 6% screening rate. So in the United States, we are far below the current goals that we're setting to detect early lung diseases. We have the United States Preventive Service Task Force helping us with recommendations. They are currently recommending low-dose CT scans for adults aged 50 to 80 years old who have a 20-pack year history and who have quit within the past 15 years. So, these are really great recommendations, and they have really helped us to detect many, many lung diseases along the way. These same guidelines, however, exclude anyone who has not smoked for greater than 15 years or who develops health problems with substantially limiting life expectancy, or they have a decreased willingness or ability to have the curative lung surgeries. So while the guidelines are very strong in terms of recommending who should get the scan, they're a little exclusionary, and we're going to explore that concept in just a moment. So the limitations around assessing care through the CT scans and PET scans seems to be a big fundamental issue. And so screening for lung diseases is considered a challenging proposition, and one that's going to require innovation and an evolution of these guidelines to improve the outcomes we're hoping for. More recent data has evolved that actually shows that if eligibility criteria in the United States were actually to broaden for former smokers from 15 to 20 years since quitting, we actually estimate an additional 4.2 million former smokers between those ages of 55 and 80 would be eligible for lung cancer screening. Now, taken at our current 6% screening rate, which is again very low, that's an estimated 300,000 more cases of lung cancer detected per year in the United States alone. That number increases significantly if the 6% screening rates were to improve, which we hope they will. We're going to explore the upshot of implementing MRI as a new option for screening lung disease, given its increasing availability and total absence of radiation, but to also understand MRI's limitations with evaluating lung parenchyma, which is real. We'll talk about things like the signal loss from lung motion, low signal intensity due to paucity of protons, and even the inhomogeneities of the magnetic field induced by air and tissue interference in the lung. So certainly MRI is not a perfect modality for lung disease. We're going to be very straightforward about that, and we do provide recommendations for the ideal processes. The flip side, though, is that lung disease cancer screenings are relying on CT and PET scan, and those are the preferred modalities for very good reasons. They also have their own drawbacks. The amount of radiation exposure, especially if you're having to get a CT or a PET scan on a regular basis, significantly increases annually once you start to do those scans twice a year, 3 times a year. The disease progression required to justify those tests is sort of an insurance nightmare, that we rely on the insurance companies to help gatekeep these procedures. And in order to qualify for the test, you must have X amount of disease. Our goal is to detect diseases early, and once again, we'll explore the idea of why that's such an important concept with lung cancers in particular. Happily, I can report that the recent article that has proposed some updates in the applications of MRI in pulmonary disease are really going to help advance the concept of using different techniques through MRI. We have now evolved advances in MRI pulse sequences, multi-coil parallel imaging, acceleration methods, and then the increased availability of the software itself that helps process the images. Now, not all of those are available in every imaging location around the world. We understand that that's a common limitation. And certainly some of these sequences are not available as part of a whole body MRI, for instance. So not a perfect solution, but certainly a step forward, which is where this technology is taking us. The transition to MRI from radiography-based methods is driven by the fact that MRI does not impact ionizing radiation, which is particularly important for, we'll say, younger patients, younger than 18 in particular, who are still developing and their telomeres in their cells are still evolving, and we want to keep them as low radiation exposure as possible. Patients with chronic illnesses, cystic fibrosis, for instance, or sarcoidosis, are getting exposed to these scans on a periodic basis, and that exposure is a problem. Pregnant women, of course, we do our best to limit exposure to radiation, and MRI presents an opportunity for us to actually be able to image pregnant women without harming the fetus. And then patients requiring extensive longitudinal follow-up, those hoping to reduce the number of surgical interventions. This is really interesting, that currently we estimate around 2% of biopsies in the lungs are leading to false positives. So that's an intervention that didn't have to happen 2% of the time. And then 2.5% of biopsies result in an adverse event. So if something actually negative has happened to that patient because of the biopsy itself. Those are numbers that can be improved. And 2 out of 100, 4 out of 100, they don't seem like massive numbers when you consider how much disease is being detected and biopsied. But that's 4 of our loved ones that could have been spared an unnecessary procedure out of 100. And MRI is going to help us achieve the ability to rule out some of these diseases and avoid some of these procedures. Physicians who may need to modify their surgical approach benefit from the MRI techniques. And then this is a really important one. Patients who may not necessarily be great candidates for surgery for any reason, whether it's coagulation issues or frailty, MRI surveillance will allow us to follow these patients without intervention and have a level of comfort that tells us that the disease is not evolving. So we start to feel more comfortable with the patient with a lung cavity or with fluid in their lung not getting thoracentesis or biopsy because the lesion hasn't changed on serial MRIs. And that completely changes the trajectory and outcome of that patient's case. One of the important factors when it comes to screening for lung diseases is having a rating system, something in a screening protocol that you can categorize your patients into to help understand what their risks look like. When it comes to screening lungs, the most valuable tools are LUNG-RADS and, of course, the Fleischner Society guidelines. The challenges with each of these systems is that they do not address the non-nodular and non-cancerous lesions. So guidance often defaults back to a provider's own intuition based on the appearance and irregularities that they see on the CT scans, and then how they're able to track those on subsequent CT and PET, and again, other radiation exposing techniques. The Fleischner Society guidelines, perhaps the most well-known, are ones that the primary care physicians see quite often, especially when they do low-dose CT scans for lung nodules. We have become very accustomed to seeing these CT protocols recommended by the Fleischner Society. And these recommendations usually guide us into follow-up CTs and follow-up PET scans. So we've got pretty good scoring systems, rating systems for the cancerous lesions, but we are still lacking in non-cancerous lesion guidance. The common clinical indications for pulmonary MRI, we're going to divide those into the non-cancerous and then the potentially cancerous lesions. Non-cancerous will include things like cystic fibrosis, tuberculosis, pleural effusions, and some interstitial lung diseases like sarcoid. And then Dr. Salinas will be really instrumental in helping us look at cases that are more likely cancerous or high risk for cancer. So we'll kind of split this up into 2 halves moving forward on the cases here. The first condition I want to look at is cystic fibrosis. Detailed conditions here, we have to be able to differentiate the pleural tissues, and currently using CT scan, we're able to get, we'll say the images here actually show you the bottom right there, CT images, whereas the images at the top are really showing us a lot more definition of the cystic fibrosis lesions. So we're demonstrating bronchiectasis, mucus plugging. These are details that are now allowing MRI to be used as a standard of care in Germany, and we hope to be able to spread that standard of care across the world. Again, cystic fibrosis patients are young children, and so trying to avoid radiation exposure, MRI gives us a great opportunity there. It helps us identify airway wall thickening and consolidation and atelectasis. So these other complications that arise because of the cystic fibrosis, which may or may not require interventions. So we've got really great options now for cystic fibrosis patients to undergo serial MRIs to be able to track the progression of their conditions and then intervene when necessary, much more clearly than what we can currently see on CT scans. The next condition I want to discuss was tuberculosis. Gladly not a very common infection here in the United States, but still worldwide very, very frequent incidence rates. Given the chronic nature of tuberculosis, again, serial scanning, repeat monitoring are standards of care. An X-ray, CT scan have become those standards at current. But that's, again, we'll take, for example, a CT scan 1.4 millisieverts for a low-dose CT, and that's compared to 2.5 millisieverts per year is the average radiation exposure for, we'll say, an American. So we're getting that amount of radiation in one CT scan, which we'll repeat weekly or in some cases daily when patients are hospitalized. And then that starts to really exceed the EPA recommendations for radiation. A 2019 study on the use of MRI to detect pulmonary tuberculosis found that the T2 weighted MRI sequences were as successful as CT in detecting non-calcified nodules with highest sensitivity for lesions at 5 millimeter. So again, we have really great evidence to support the concept of MRI over CT in cases of tuberculosis. The next condition are pleural effusions, another common one in our cardiac ICUs and in our pulmonary rehab centers is that we will find patients who have sometimes incidental, sometimes diagnostic levels of pleural effusions. And now the question is, do we tap them? Do we perform thoracentesis to drain the fluid? Or are we able to watch it and surveil it and allow it to evolve on its own, resolve in many cases? So in this case in particular, we've got effusions found on a polycystic kidney disease patient over a 5-year period. And using this MRI surveillance technique, the patient was able to avoid thoracentesis because their fluid level stayed stable. And that, again, is a very protective technique to avoid thoracentesis, which has, as we know, significant complication risks associated. Lastly here, I'm going to touch on the interstitial lung diseases, which is sort of a developing concept for MRI. These images I'm showing are from a 47-year-old patient with rheumatoid arthritis who's developed lung disease as a complication. The far left image is from the CT imaging, indicating subpleural interlobular septal thickening. Image in the middle is a T2 weighted MRI showing mild hyperintense lesions along the interlobular subpleura. So this is actually showing us active inflammation over what looks like maybe thickening and hardening on the CT scan. So far right is a Petra sequence confirming those MRI findings. This became very important for this patient because now understanding that there's inflammation over thickening and hardening, this patient was actually able to get treated with a different protocol. They were treated with a series of anti-inflammatories, and that pleural effusion was able to resolve, that inflammation, was able to resolve. And this patient had a much better outcome thanks to the use of MRI over CT scanning. In this particular case here, we've got a CT scan showing CTD related, that's connective tissue disease related interstitial lung disease on the high frequency CT scan. And that shows probable interstitial pneumonia with bronchiectasis. On the right, we have the MRI images showing right lower lobe hyperintensity. So this fluid, again, not pneumonia, was able to get treated with anti-inflammatories as opposed to spending time treating this patient perhaps with an antibiotic, which would have been inappropriate in this case. So here, finally, on the interstitial lung diseases, we see a case of sarcoidosis on the high resolution CT scan on the left and the middle, and then with more clarity on the right, the same patient with a T2 weighted MRI. We can particularly make out here an enlarged calcified lymph node in the right paratracheal region, and this has what they call hypointense core or dark lymph node sign, and that indicates fibrosis. So now on this sarcoid patient, we've arrived at a different diagnosis of a fibrotic lesion. CT scan alone would have required a biopsy to get to that diagnosis, whereas here on the MRI, we were able to spare the biopsy, confirm the diagnosis, and sort of move forward with the patient's case without intervening that way. So these cases were really, really significant to me because, many, many times we are treating non-cancerous lesions. I'd like to hand it over to Dr. Salinas, however, who's going to walk us through more cases that have to do with lung nodules and potentially cancerous lesions.
Thanks, Vikash, for that. Yes, hello everyone. My goals for today are to demonstrate several straightforward lung cases. Unfortunately, we do not have easy access to patient pathology reports or other imaging once they proceed elsewhere for their care. So our focus today will be whole body MRI findings, the radiologist workflow, and a brief overview of our ONCO-RADS nomenclature. Here we have our first case study, a 47-year-old female with no significant past medical history. Here in front of us we have the typical form which we, the radiologists, see from the patient's medical intake. Our form is separated into organ systems, which show known diagnoses on the left-hand side, current symptoms in the middle column, and relevant family history in the far right column. So here we have our axial T2 sequence, our axial diffusion, and our coronal T1. Here in that left upper lobe, we see a thick-walled cavitary mass with central low signal on T2, measuring about 3.8 by 3 centimeters. It shows very marked diffusion restriction, and we have some satellite nodules posterior to the primary mass, as well as abutment of the left lateral pleura. Again, showing that marked diffusion restriction, very concerning for a highly cellular neoplasm. So we would categorize this as an ONCO-RADS 5. And we have an additional right upper lobe 7 millimeter nodule, which is indeterminate in this patient with what looks like a neoplasm. And again, on our coronal T1, we have similar findings showing that in a different plane. So our impression for this one would be a left upper lobe thick-walled cavitary mass, highly concerning for neoplasm. Our ONCO-RADS score of 5, malignant finding highly likely. Our follow-up recommendations as of right now would be for the patient to see their clinician and to obtain a CT thorax for further evaluation of both this primary mass and that right upper lobe indeterminates 0.7 centimeter nodule. Case 2. We have a 54-year-old male who's coming in just for proactive screening, no significant past medical history. The slide that are moving right now is your axial T2, which shows a 3 centimeter mass in that medial right lower lobe, which additionally shows prominent hyperintense signal on our diffusion sequence. Now we're going to go ahead and pull up our ADC map, which corroborates this finding, low central ADC signal, again concerning for a solid neoplasm. Our far left, we have our coronal stir, followed by our T1, and our diffusion sequence. On stir, we see this mass is bright and low on T1, and again, this diffusion-weighted sequence on a reformatted image showing that hyperintense mass, as well as maybe some mid-thoracic spine end plate changes, which are incidental. So for this one, it was read out as a right lower lobe, 3.8 by 2.8 centimeter mass, again, highly concerning for neoplasm, an ONCO-RADS score of 5, and a clinical follow-up and CT thorax were recommended for further evaluation. Our third patient is a 65-year-old male, again, no significant past medical history. We have some nodules here on our coronal T1, but we also see some reverberation or respiratory motion artifact in our lung bases, one of our limitations here on MRI. Again, we see a 4 and a 7 millimeter nodule in that right lung, which we then try to triangulate on our axial T2 and diffusion weighted sequences. Pretty challenging to see, so we pull up our axial T1 weighted sequence of the upper abdomen, which kind of has thinner slices through the lower lungs, which corroborates that 7 millimeter nodule being a true nodule on our large field of view coronal images. As we zoom in on our axial T2, we're going to see some areas of cystic spaces which are concerning for potential emphysema, as well as some perihilar ground glass opacities which may indicate air trapping or some mild inflammation. And in our right lower lobe, we see more prominent findings showing that cystic space in that right lower lobe, telling us that this patient may have some undiagnosed emphysema. So this case was read as multiple lung nodules throughout lungs measuring up to 7 millimeters for an ONCO-RADS score of 3. Benign finding is likely. However, a clinical follow-up was suggested. Again, we suggest follow-up with CT thorax for both assessment of these nodules and the patient's emphysema. We have two options presented to us. We could either follow those Fleischner guidelines, as this patient could be bumped up to high risk and get a follow-up CT at 3 to 6 months, then again at 18 to 24 months. However, given the emphysema, perhaps the patient has a smoking history and may be eligible to enroll in a low-dose CT surveillance program, at which point they would follow lung-RADS criteria instead. Case 4 we have is a 39-year-old female who has a known history of breast cancer and has completed mastectomy, breast implant placement, chemotherapy, and radiation. She was stage 2 at the time of diagnosis. Here we have our axial T2 sequence and our axial diffusion sequence. We're showing some subpleural reticulation here in that right lung. In our coronal sequence, we see this large, spiculated, ill-defined mass in that right upper lobe, as well as some satellite nodules in that right lung apex. Given the patient's cancer history, this is concerning for potential metastatic disease and warrants further investigation. Now, I say this is for historic assessment because we no longer screen patients with active cancer, as we do not want to confuse the clinical situation. So this is, like I said previously, strictly for historic purposes. So this was read out as several nodules or masses concerning for potential metastatic disease. An ONCO-RADS score would not be applicable in this situation. We gave the differential diagnosis that this may be therapy-related pneumonitis, could be related to her radiation or chemotherapy, and also presented an even less likely differential of multifocal pneumonia in the absence of symptoms. Our last case is a 39-year-old female with a history of a CHEK2 mutation. There's only one finding here in that anterior left lower lobe, which is going to be this solitary nodule. We're going to zoom in on that. And it comes out to about 8 millimeters in average dimension on our axial T2 sequence in the bottom right tile. Now we're going to go ahead and look at our coronal stir and coronal T1 zoomed in on that lung. And again, we see that nodule is in fact a real nodule. And we can hallucinate a faint amount of diffusion signal on our DWI sequence in the bottom left-hand side. So this was given an ONCO-RADS score of 3, benign finding likely, as lung cancer is not an association with a CHEK2 mutation, which stands for checkpoint kinase, which is a tumor suppressor gene. So this patient can follow Fleischner guidelines for a solitary lung nodule and receive a CT in 6 to 12 months. Next slide. Now, the reason I included this slide was because I thought this mutation was rather interesting. Patients with CHEK2 mutations do have a predisposition for breast and colon cancer. However, their issue is also exacerbated by additional ionizing radiation exposure as that tumor suppressor gene is inactivated. So for these patients, it may actually be a more useful tool in the event that they do have an indeterminate breast finding to undergo breast MRI or ultrasound, which would save them from that ionizing radiation exposure. And in the future, we hopefully can refer these patients for diagnostic lung MRI for potential surveillance, as Vikash mentioned earlier in this presentation. Now, you've heard me speak about ONCO-RADS, which stands for Oncologically Relevant Findings Reporting and Data System, and represents our guidelines for how we report whole-body MRI findings in the context of cancer screening, and also stratified based on patient risk factors. The goal of ONCO-RADS is to create an organized report which is reproducible and succinct. In that regard, we have 5 different categories, with category 1 being normal, 2 benign, 3 likely benign with more intermediate features, and 4 and 5 as malignant findings. This chart demonstrates our pathway for abnormal lesions and shows how that next step is modified based on risk factors. Here we have a simplified version of that chart, which shows how the general population versus higher risk population would be categorized. If we take that same patient with the CHEK2 mutation with a score of 3 intermediate, you would see the general population is stratified differently than the higher risk population. A category 3 lesion would be worked up for perhaps further investigation and biopsy, as those patients have an increased inherent risk for malignancy. So a novel feature of this ONCO-RADS system is that the whole body MRI scan can be repeated rather liberally without added radiation dose to the patient, which allows us to bump up those more intermediate high-risk population patients. Next slide. So here we have similar boxes, only in this slide we have the abdomen and pelvis focus here, and the nice thing about ONCO-RADS is that it does cover the entire body. And here we have the same table for category 1 through 5 as it relates to bone and limbs. As you can see, it does take quite a bit of an experience for a radiologist to be comfortable with every single finding from every single body part, as well as their associated ONCO-RADS score. However, we are implementing this, and as we get up and running, we hope this will generate a wealth of research information as well as clinical applications. As we continue to grow and evolve our practice, we can hopefully explore standardizing our report outputs in similar language to BI-RADS, LI-RADS, lung-RADS, and so forth. As you can see on this page, our ONCO-RADS scores of 1 through 5 have very succinct and straightforward language, which we apply to the lesions in question. We hope this will streamline clinical planning and patient understanding in the future. Here's a very long conclusion statement by the ONCO-RADS team, basically emphasizing what I have already said previously. And we hope our efforts here at Prenuvo can aid in exploring many avenues and validating research through clinical trials and creation of AI platforms to continue help in both detection and analysis of these lesions. And with that, I hand this back to you, Vikash.
Thank you so much, Dr. Salinas. Seeing those cases, some give me goosebumps because these are such advanced cases, and in some cases so early, and we are really striving to detect these things as early as possible because of the incredible outcomes data that is coming from early detection. So drawing sort of a packaged bow around the idea of lung cancer detection We have now some really strong evidence published in 2020 that indicates that MRI is comparable to low-dose CT in lung cancer screening programs, especially for nodules 4 millimeters or greater. So we've now got a great database of support to say that MRI can be utilized, that full body MRI, whole body MRI could be the modality to implement screening programs, and that PET-CT in the future may be helpful, again, to further characterize these pulmonary nodules, but detection may come from the MRI pathways. At Prenuvo, we are supporting this initiative to expand screening guidelines to include more patients with risk factors, the patients who are now 20 years out from smoking rather than just 15, and to be able to utilize whole body MRI as an adjunct to X-ray and low-dose CT protocols to really help catch these early stage cancers much sooner. We want to try and match these numbers for colorectal cancer screening and breast cancer screening at the 70 and 80% levels, where we've got so much room to grow at the current 6% screening rates. And we also want to be able to provide a service that reduces unnecessary biopsies and surgeries and worry in patients who end up having low-risk lesions that we can surveillance on a routine basis with our low implementation, absence of radiation technology. And so by doing this, the 6% rate should improve, and consequently, a significant number of lives will be saved. The survivability, I just want to finish on this point, really depends on early stage detection. That 5-year survival rates drop to less than 20% at stage 3, but is double that, over 60%, when lung cancer is detected at stage 1. So the USPSTF is working to improve these recommendations. The American Cancer Society has recommended 20 years past smoking to continue screening for lung cancer, and we support that. And the incidence of lung cancer will undoubtedly continue to go down as we implement smoking cessation programs, as treatments for lung cancer improve. We also understand that there are a number of non-neoplastic processes, and early detection and surveillance of those, such as sarcoidosis and interstitial lung disease, can really be influenced greatly by the use of whole body MRI. So that concludes our portion of today's chat.
Thank you very much, Dr. Modi and Dr. Salinas. I appreciate everybody's time and effort in attending today's webinar. This is where we will wrap it up, and we'll see you in a couple of weeks for another webinar where we talk about another condition and how we are impacting the healthcare systems at Prenuvo.